Hello, and thank you for taking the time to come and watch this presentation today. This is an information presentation that we presented on the 31st of March here in the Midwest Foot Clinic based in Barrackview in Limerick City. What I'm going to go through today with my colleague Yvonne is the service that we provide here in the HSE Midwest Foot Clinic and the types of referrals that we accept, our referral criteria, and a little bit around technology that we use in clinic. I would like to start by presenting my esteemed colleague Yvonne Buckley, our senior musculoskeletal podiatrist. She has been working as part of the Foot Clinic since October 2020. Yvonne graduated from NUI Galway with a first class honours in podiatry in 2016. She also has a Masters in Motion Analysis from Dundee University in 2022. She is an expert in gait analysis where she really comes into her own. She's a love for technology and a passionate interest in research. She has worked both publicly and privately and has presented case studies at conferences as well as guest lecturing on the undergraduate course for podiatry.
And I'm delighted to introduce Sandra Caulfield, the clinical specialist MSK physio that I have the pleasure of working with. She just joined us in January and she has worked in the area of MSK physiotherapy for the past 16 years and has gained her Masters in Brisbane in 2010. She's worked internationally in an array of settings, most recently joining us from MSK Triage, Orthopaedics Rheumatology and the Poinsettia Clinic in the UL Hospital Group. She's very passionate about progressing the advanced practice career pathway for physiotherapists in Ireland and advocating for improved patient services in the Midwest, and she's a pleasure to work with.
Thanks, Yvonne.
So as a podiatrist, so what we handle is the at-risk foot, footwear, foot orthoses, ankle foot orthoses that are non-complex. We give footwear advice, we give exercises, and we give load modification.
And as physiotherapists, our toolbox for the Midwest Foot Clinic would include exercise prescription, motor control retraining, gait re-education, orthosis as well, footwear advice, manual therapy, taping and load modification. And between both disciplines we provide the best evidence treatment for foot and ankle pain. So the objective of the Foot Clinic is to provide an integrated pathway for the provision of orthotics and footwear in an equitable and timely manner that reduces physiotherapy, podiatry and aids and appliances waiting lists. It also aims to encourage teamwork across disciplines and services in order to maximise cost effectiveness while providing best quality care for patients and improved access via single point of care, and that's here in the Foot Clinic, but we are based between Limerick, Ennis, Neenah and Thurles.
So there's a lot of people who have gotten this project off the ground. We could be here all day thanking people, but these are just some of the groups that have really helped get this off the ground, from aids and appliances all the way through to the communications department, and we just want to acknowledge all their fine work to date. And obviously we have a lot of clinical people involved and clinical managers historically and presently, and these are some of the clinicians involved at the moment. So this is just a timeline of how the Foot Clinic began. Obviously it has its origins in 2016 all the way up to the present day. So this you can stop and have a look through. We won't dwell on it too long, but it's just a big long timeline of where the Foot Clinic started.
And it truly is a ground up service. Back in 2016, Aids and Appliances in North Tip would identified that the orthotic work stream was a huge area of expenditure for them, looking at over 122,000 for a year, where GPs were referring in for orthotics and an external company was providing the devices, and you're looking at maybe €200 to €300 per device. The physiotherapy department, Carmel Murray, the physio manager, and senior MSK physiotherapist Maura Cleary were involved here with looking at this waiting list and expenditure, and with the pathway that they developed, they saved 18,000 in year one. A lot of education went to GPs and consultants on this referral pathway, And there was a huge input from all different disciplines, particularly getting the go-ahead from Kate Duggan, the primary care head at the time, Pascal Donoghue, and the project management office. And this is where the orthotics working group development began. And in with that, then podiatry were doing their own thing in Clare, which Yvonne is going to go through.
So in 2019, podiatry secured Sláintecare funding for SIF 343, which was a podiatry project based around dealing with the waiting list for aids and appliances for orthotics in North Tipperary and Limerick, and also for the reducing of offloading stock needed in the Midwest as well. So they came out with a savings of 56,604 on project stock versus the actual quotes that have been sent into aids and appliances. So it's an 85% saving overall. There was a 75% reduction in the waiting list for footwear and orthotics in the Midwest. And during COVID, there was a rapid access clinic where offloading stock was available to service users, and 53 service users with an active foot ulcer avoided ED. The project was simulated in July 2021. And out of that became a lovely PPG called the Integrated Pathway for Foot Orthoses and Footwear in the HSE Midwest Community Healthcare, which kind of outlines the actual steps of the PPG and is a kind of a clear kind of pathway for what the service actually achieves. And it's available on request if anyone wants to read it. So this lovely flow chart really kind of maps out the service, and that came out of the PPG as well. So we accept a referral from the Midwest Foot Clinic at hse.ie. We really prefer email referrals. The referral is screened by the podiatrist to make sure there's no high risk foot. If there is, we will sidetrack that to our main community podiatry service. And then if it's not, it goes into our fortnightly joint triage with my lovely physio colleague Sandra and the CDNT, the Children's Disability Network team physio representative, so that they have input into where our referrals are going as well. And then the decision is made based on the clinical discussion about what priority this patient is given and where their most appropriate care is.
So the eligibility criteria for referring into the Midwest Foot Clinic would be children and adults who reside in the Midwest Community Healthcare region. Podiatrists really look with regards maybe the vascular neuropathic presentations and the diabetic foot with musculoskeletal complaints. And then from a physio perspective, we'd be more, I suppose, involved with foot and ankle pain and altered foot biomechanics. But that's not to say that we both don't have a hand in all these presentations. Just so you know that if you are referring in a non-medical carriage holder or a non-long-term illness carriage holder, they will be seen and assessed, but they have to self-fund their devices, and we have patient pay pathways for this. Our exclusion criteria for the foot clinic would involve acute trauma, acute fractures and acute soft tissue injuries, and we will see these patients down the line once the consultants have given us the go-ahead. So we have a list of referrals, I suppose, and we have internal referrals, which would be anyone who's a member of the HSE primary care teams or the network services, or the physios that are employed in the Children Disability Network teams. And then external referrals would be people with outside this remit who could still refer. So we're accepting referrals from everyone really, as long as you have seen the patient yourself and you've done an assessment and referring them in from there. So as Yvonne has said, we prefer email communication through the Midwest Foot Clinic at hse.ie email address. It's more sustainable, it's easier for us to track, there's less room for errors and incidents. So if you can email in, we have an electronic email referral form that my colleague Yvonne has spent a lot of time doing up for us, where we got input from our GP lead Ken Cahill on regards to how they would find best to refer into us. It's an international classification framework based referral form, and so is our assessment and our prioritisation. So basically we're looking for functional problems, activity levels and participation. So really that's the bit of information that on the referral form we really need. Are they affected? Are they not able to participate? How long they have had the symptoms for? And again, have they any diabetic or vascular history or anything of note? Yvonne, with regards to P1 for podiatry, might be easier for people to understand if you give an example.
So it's generally a diabetic and obviously a reduced activity level if they've not able to walk. Obviously we really promote people with diabetes being active for as much as possible, so that would be P1.
Yeah, and for all our paediatric population are P1s, so they're I suppose we have a bit of a bias in our waiting list then, that all our paediatric patients are seen as quickly as possible, but also then anyone who's in significant amount of pain or on sick leave because of their impairment, or a child who's limping, we're going to see them urgently, and we'll keep urgent slots. So if you ever have a real concern about somebody, we'll always have an urgent slot for them within a 2-week period. So don't be afraid to ring us or email us about those patients you're very concerned about. The main details that we want that sometimes miss and will be sent back to the referrer would be name, address, date of birth, things that we would see as I suppose basic, but they can be missed and the referral form will be sent back. They need to have functional impairment or limitation to access our service. There has to be a clear clinical need for a footwear or orthotic intervention, and a huge percentage of what we see, they need to be assessed and they need education, and we need to educate the referrers, but they often don't need an orthotic intervention. But that's important to do the assessment and to educate the patient and the referrer. And there's always a clinical discussion. So if you feel that we need to do something for you and we haven't done it, we're happy to talk to you. Pick up the phone, talk to us, and we'll try and provide the service that you need for your patients. So with regards to some referrals that perhaps that I've seen since January that have come into the clinic, we might get a referral for a plantar fasciopathy that might be maybe 6 weeks history. And with regards to natural progression, we know that these patients are best served with footwear advice, education, exercise management, and that can all be done in primary care physiotherapy. So a lot of referrals we redirect back to primary care physiotherapy, and if they're not resolving or getting the natural progression that we'd like to see, then we'll see them here in the Midwest Foot Clinic, and we will work with physios and podiatrists and other health professionals to get the patient to where they need to be, or we can take them on ourselves and work with them alone. So just to remember that, I suppose, we're not the first stop. When physio is the first line of management, they're going to be seen by the physiotherapists in the community, and then we will come in and help if the help is needed, and physios will talk to us about what their patients need.
So this is a breakdown of the referrals from 2022 to March 2023. Just a short snapshot, and we have a nice bit of physio back in because of our lovely Sandra. We have a lot of joint clinics between myself and Sandra, so that is at 13%, and that's a really good clinic because patients get a lot out of it. The joint CDNT clinics, that is myself generally going into the cash services and working with my physio colleagues in children's disability teams, and the joint orthos clinic is about 1%.
And we've had 2% inappropriate referrals, which are kind of pain-free pes planus with no functional impairments. So just because a person presents with a pes planus, a pronated foot, does not mean necessarily that they actually need an orthotic. So it's unless their function is impaired or they have pain, then we look at them for those reasons. So 2% are going back to referrers.
So this is a little slide on the outcome of podiatry from the past few years that we've collected. So generally 34% have an off-the-shelf device, and then 29% have custom-made foot orthotic, modular footwear, which is footwear which is off the shelf but has had slight alterations to it, is 3.45%. Off the shelf footwear is a bit higher at 8.62%. Exercise and review again is 18%. And patient pay, which are the people who do not have a medical card but have attended for assessment, is about 3.45%, and bracing is 3.45%.
And just on that, Yvonne, there's a huge amount of evidence, isn't there, to say that our off-the-shelf devices are as effective for management of conditions as custom-made foot orthosis. But then there's certain conditions like JIA and rheumatoid arthritis who may need the custom-made orthosis. Yeah. But just so referrers know that they are as effective.
Especially in our pediatric population, because they grow so quickly and you get them to them faster, so they get the benefit of it faster as well.
And the other thing we'd say in that one is that the patient pay is going up a bit. We're getting a lot more referrals for patients who are non-medical card holders. There's been a few retirements of maybe physios in the area who used to do a lot of orthotic prescription, so now we're getting them into clinic here as well. So kind of our I suppose our stats are changing a lot recently.
It's a very kind of transient time as well with the service, so there's always going to be a bit of change.
So our waiting times at the moment, our P1 waiting time is 0 to 3 months wait. And as I said, we have those urgent slots. It's kind of biased because all our pediatrics, all under 18s, will be seen as a P1. And then a P2 is 3+ months, and currently it's about 5 months. So just to go through what we do actually in clinic, we go through a full clinical assessment. Patients are often kind of surprised why we're looking up the chain at their spine and that, but we will do a full assessment subjectively and objectively. It is in the International Classification Framework impairment focused, and we'll go through what the previous management was, the foot function index. And from an objective perspective, we'll go through posture, gait analysis. We use rheumatology proforma so that it's standardized across podiatry and physio, the PGALS pediatric, gait, arms, legs and spine, or the adult version. No rotational profile, particularly for our children. Range of motion, strength and neurological examination is always done because we will often pick up things in clinic, just like our MSK triage colleagues do in the hospital, and we look at function. Management we've kind of gone through before in prescription, and just so you know, with regards to our review, if we do prescribe a device for a child, we'll review them every 2 sizes or after growth spurt, or if a parent or a guardian rings us with concern. And with adults, we'll review them 6 to 8 weeks. But a lot of the referrals that I would see for MSK, we're discharging them after the first appointment. They actually don't need us, they need exercises and physio. So just so you know the pathway.
So this is a patient testimonial from one of my patients. So she attended with post-hip dysfunction. She was unable to walk, really not able to participate in her hobbies. She was a very active lady. So she says her foot pain has improved considerably since the start of the treatment for her, and it's been very effective. And her quality of life has improved considerable, especially as she's now able to do the things that she used to enjoy: walking, getting better, cycling, swimming and minimal pain. And the last time I spoke to her, she was getting back into the garden. So where we are now, so we have our lovely Sandra on board, our clinical specialist physiotherapist. There's an approval for a clinical specialist podiatrist. That job has to be advertised. The waiting list for footwear and orthotics is controlled by the HSE Midwest Foot Clinic. We have a good thorough referral system in place. We have great joint clinics implemented, and the next part is our stock management system.
So this is what we'll be rolling out in the next quarter among our physiotherapists in primary care. So we have access to off-the-shelf devices, and we'll be training up the physios in primary care to have the database to be able to prescriber to issue stock to patients from their local clinic, which will just improve patient access in line with Sláinte Care policy. And I suppose it'll ease the burden then for the more complex patients to come into the Midwest Foot Clinic. So I think it'll kind of give better access to patients and to physiotherapy therapists to devices in the long run. So it's a great thing. So watch this space.
So a bit about innovation and the Midwest Foot Clinic. So as Sandra touched on in the beginning, I love technology, and what we're doing is trying to use technology to get the best patient outcomes and to speed up our service as well. So technology is our friend. So we have 2 3D CAD/CAM scanners for the faster manufacture of footwear and orthotics. So this has cut down our postage, packaging up, going to the post office and posting off phone boxes, and it's also much more environmentally friendly way of doing things. We also have an in-shoe pressure system for an additional assessment for patient education. For this kind of technology, what's really good about it is patients are really responding to visual kind of parameters. They can really see where they're not loading or where they're overloading, and also it's good for those patients that that there's something that you can't quite figure out and that you need the help of a more detailed system that can see things that our eyes can't capture in millisecunds of seconds. So it's a great service and a great toolbox. So this is some of the data that we have collected. This is your center of mass, and your center of mass is based around your pelvis, and as you walk it should kind of rotate from right to left in an equal pattern. On the left we have a normal gait, so it's kind of 2 sides of a butterfly wing, and you can see it's kind of equally distributed on either side. On the top corner right corner there is a toe walking gait, so it's very squidged down. It's not very equally distributed at all at the forefoot and all higher up, rather than being equally distributed between posterior and anterior. The middle one is an in-toeing gait, so it's much more rotational gait, and it's a wider kind of butterfly, not the full normal gait, but it's a bit wider than your toe walking, because they use actual full rotation, but it's a bit more wider because of the extra rotation. And the bottom one, it's a bit cut off, is a cavoid foot type. So again, loading the lateral border a lot more, wider again than your in-toeing gait, and obviously not as rotational as you would fully want, or not the full length of anterior posterior movement as normal gait.
And it's kind of good for reassessment, isn't it, Yvonne, that like when you put in a device, then you can see that their center of pressure has improved.
Yeah.
So I suppose if you're looking for, you know, your functional improvement, your subjective improvement, but also then objectively you want to see that we're being effective as well with the load across the joints.
Yeah, and it's great to have that kind of the numbers behind it, you know, what we're doing. So it's a
patients love it.
measure. Yeah. We have a scanner that we use for creating kind of a last almost for a foot. So this creates a full 3D model of a foot, so that we can develop footwear off of it. And like, this patient can't get off the shelf shoes. He has to have his own last med. He has a genetic deformity which has resulted in him having a higher BMI, and so we have made a lovely pair of custom boots for him, and he's walking much more, and it's reducing the load on his other joints because it's got a lovely shock absorption orthotic inside as well. And this is great because traditionally you will be messing around with plaster Paris and measurements, and this is far more accurate. You can see the actual model makes the measurements for you, and we can just send this and email it directly to the lab for manufacture.
And he was like over a size 15 or so, was it?
Yeah, so plus 15, you have to really go into kind of a custom made shoe. Sometimes you can get, like, in America you can get size 18, but other than that, like, it's really hard to get actual shoes and boots. And as well, for his BMI was increased. So.
Yeah, and the other thing that's really interesting is, like, that pair of shoes is going to cost the HSE €600. So we should be very, I suppose, smart about how we use the expenditure here, and make sure that the patients who really need the devices are the patients who are getting the devices. And that's why it's so important to follow evidence-based guidelines around prescription of orthotics, AFOs and footwear.
Yeah, it's people who need it get it the most.
So just, I suppose, with regards to our future, sorry, Yvonne, this is Yvonne's bit because she wants to talk about her gait lab and that's for funding for it. So do you want to go for it, Yvonne?
Well, you know, it would be nice to have a lovely gait lab to increase the specialised service which we're providing. And
I think it's a basic in some regards, because we're still analysing visually ourselves, and really we need a bit more space to actually allow a patient to walk down a corridor and back and be able to view it from both sides, both angles, front and side.
Yeah, I mean, like, it's the gold standard is that you have a gait lab and you can do 3D motional analysis, and you know, that's where the future is going with regards MSK and biomechanics. So it would be great to be a forefront leader in Ireland on this.
Yes, it would. If anyone wants to fund it for us.
Education session is your bit, Sandra.
Yeah, and so that's what we're doing today, is a very brief overview of just what we do and our referral criteria. And if you have any interest in us coming out to you and doing an in-service training with yourself and your colleagues, we're more than happy to. I would just say to let us know what your learning needs are, and I can always send out a learning needs survey. But what are your basic learning needs? What can you do in clinic yourself as a nurse or as a physio or an OT, where we can help you with that, and then what you need to refer into us for. So more than happy to do in-service training with anybody who's interested.
And we are improving the MDT service. This is lovely joint working, and we are increasing that all the time.
Across both, I suppose, primary care, community health and our secondary care pathways. So we're involved with the Children's Disability Network team, heavily involved with that. They're about 30% of our referrals, and then also with primary care colleagues and in the acute pathways, and MSK triage have been great getting involved with referring in patients. So just to, I suppose vascular and endocrinology have been referring in traditionally to podiatry, so just to increase the awareness to our colleagues across the services that we're here, and we're here to help and make sure that patients get what they need and when they need it. And our final goal then is just to reduce wait times for our patients. So looking to kind of, I suppose, getting stock back into community so physios can prescribe off the shelf devices, and that'll free us up for more complex patients and presentations inside in the Midwest Foot Clinic. That's all. Thanks a million for listening to us. I hope we didn't keep you for too long. Just to remember to contact us with any queries on this email and referrals through this email and our phone number, and don't be afraid to ring us or to email us, and we're always there at the end of the phone to help you. Thank you very much.
Thank you.